and then Russell Lemley will speak. So we're doing it a little bit backwards or contravening what we would do. We're here to talk about the impact of the cuts and chaos that the Trump administration policies have unleashed on the VA. And Mark is going to talk. I'll give a broader portrait of this, but Mark is going to talk about the cuts and the chaos at the ground level. Mark is the president of NFE, National Federation of Federal Employees Local 1 at the San Francisco VA Medical Center. I met Mark and wrote about Mark. If you want a profile of Mark's work at the VA, you can read my book, Wounds of War. And there's a profile of him. I met him when he was working at the West Haven VA Medical Center in Connecticut. He's an occupational therapist. And Mark is going to begin with something none of us can ignore. The whole country hopefully will not ignore this, which is the horrible murder of a VA nurse, a VA ICU nurse on Saturday. So Mark, do you want to say a few words honoring Alex Pretty and maybe lead us in a minute of silence, and then you could begin.
Yeah, thanks for that, Suzanne, and hello, everyone. Again, my name is Mark Smith. I'm the president of the National Federation of Federal Employees, Local 1 out here in San Francisco. And just to be clear, I'm speaking on behalf of myself in my personal capacity, not on behalf of the United States government or the Department of Veterans Affairs. You know, everyone has probably seen the news by now, but I think, you know, on the ground here, we are all just gutted, horrified, you know, devastated to see one of our colleagues, an intensive care unit nurse, be, you know, frankly executed at the hands of federal agents in Minneapolis. We're certainly in mourning. Many of us are organizing vigils, candlelit vigils across the country. We're organizing one here for Tuesday night. And, you know, I think we should do we'll do a moment of silence here in a second, but I just wanted to comment just on the theme of this topic. We're talking about cuts to the VA, and I was really struck this morning when I saw an image of all of Alex's coworkers in the ICU lined up in the hallway there this morning, you know, taking a moment to honor him. And the fact that, you know, we are so short-staffed in the VA that it's difficult for folks to even get some time off when their colleague has just been murdered is, I think, a stark reflection of what it's looking like on the ground right now. I was on a call on Sunday, an emergency call, and we had one of one of Alex's coworkers, a nurse named Dan, from the Minneapolis VA, and he, you know, had just come off of his third night shift in a row, you know, with mandatory overtime, things like that, because they are so short-staffed. So, yeah, we're hurting, and yeah, I'd love to, you know, take a moment of silence right now just to honor the memory of Alex Pretty, and you know, let's take a moment of silence. Thank you. Appreciate everyone being on the call today. I don't know if folks have seen the secretary's comments on the death of Alex Pretty, but I won't say too much. Just that, you know, the comments do not befit what our boss should be saying about our coworker and one of his employees, and it's just further enraging. So I'll talk a little bit more about what's going on around staffing and how things are on the ground. I can't speak too much to particular details, but I will kind of give some broad strokes. you know, obviously over the last year, with many of the cuts that have been happening, morale was already low. We were already struggling to, I think, do more with less. And then we had this most recent round of cuts announced December 19th, the cancellation of many open positions. And the official line was that, many of these positions were not needed, or they were, not necessary, and they're not going to impact veterans care by getting rid of them. I would say pretty clearly from the ground level that is not true. For many of these positions, they were critical frontline healthcare positions, and will absolutely impact care. Some of the examples of positions that were cut here would include positions like the peer support specialists. These are veterans who are hired to, with their own experience of accessing mental health or substance use care, to help other veterans navigate the difficult transition into VA care. Several of those positions were cut. We've lost social work and psychologist positions, who are, obviously providing critical mental health services and, connection to resources for our veterans. And when those positions are cut, our therapists, caseloads are already full, which that means, veterans are going to wait longer to get access to care, or they're going to have to be diverted to the private sector, where many private sector therapists, if they are taking patients at all, don't have the expertise in veteran specific issues that VA care providers have. It's all kinds of positions. Those are some of the main ones, but we lost, I think it was more than 150 positions here. And yeah, morale was already not great, and everyone's a professional, and we do our best, but I would be lying if I say it wasn't impacting people and affecting us on the front line. So that's basically what I can say for now. Yeah, I'd be happy to answer any questions or comment further on other topics if needed.
One of the things I wanted to ask you, Mark, if you wouldn't mind addressing, is what kinds of things are people doing about this, and what are you hearing from patients? Because I know that there was a rally a couple of weeks ago or last week, and I know that there's been rallies around the country, and I mean, people are obviously not just accepting this and soldiering on. So I think it would be useful as a union member, and maybe what more you think needs to be done.
Yeah, I mean, certainly we are not taking this lying down. There's been a lot of sadness and grief, I think, at what has been happening to the VA, but there's also been a lot of anger. And that anger, we've been channeling that anger into action. I would say here at RVA in particular, we've been, hosting informational pickets to provide information to the public, and rallies and things like that to get the word out about what's going on. Many times veterans or their family members are not aware of what's happening, because maybe they're just reading the official line from central office, or they're just not as aware of what's happening. And so doing those informational pickets and getting the word out, we've been doing those. We did those throughout the summer, and then have been doing them again more recently, hosting press conferences, getting the word out. There's a group of veterans and retired staff here at our northern clinic, the Santa Rosa Clinic, who have been actually rallying and informational picketing outside of that clinic every Friday for the entire year, the entire last year. They've been out there every week getting information out. And so, a lot of that collective action has allowed us, I think, to channel some of the difficult experiences we've been having into something productive, encouraging folks to contact their Congress folks, their representatives, to stop some of these cuts and other, attacks on the federal workforce just more broadly. Fighting obviously for our collective bargaining rights to get back the critical workforce protections that we need to make sure that we're able to safely speak up for our patients. A lot of times retaliation can be a worry, and having a strong union contract and protections makes healthcare workers feel safer to speak up, and that is a patient safety issue. So taking action on those issues. We had a big rally in DC most recently to pass the Protect America's Workforce Act. And yeah, we have a legislative committee in our local, which is, really benefited greatly from VHPI's work to look at the policies and legislation that's going to impact VA care and patients, and trying to advocate for that those policies and legislation with our Congress folks.
It's interesting, and I'd love to hear you answer this question. So, one of the questions is that the department under this administration has consistently downplayed the importance of clinical support, administrative, and facilities staff. Can you talk about how cuts in those spaces impact veterans' healthcare and ability of clinicians to do their work? Because I think that's absolutely true. I mean, a doctor or a nurse is gone, but a tech or a housekeeper or, a clerk, it's, who cares about them?
Absolutely. I mean, if you don't have somebody to clean and sterilize the materials or the rooms, you can't do the work that you need to do in there as a nurse or a doctor. Regarding administrative support staff, I mean, that is just so critical. There was a statistic that I think there was like a 25% increase in doctors refusing offers to come work at the VA in the past year, and part of that is the lack of administrative support. It's if you can't get people to properly schedule your patients, to take care of the administrative pieces, it becomes much more difficult to provide the care that you need to provide as a therapist or a doctor or a nurse, et cetera. All of those support staff are critical, and we can't do our jobs as clinicians effectively without support staff. We need everybody.
Yeah, there's another question about Mark, how is your union and SF still active as the Heinz VA Chicago unions are gone? One may not even utter the word union there.
Well, to that I would say unions are not gone. We got kicked out of the office that we had on this facility for 25 years, but we are the union, right? Unions existed in the federal government for 40 something years before they got collective bargaining rights. It's really just a group of workers who take collective action together. And we don't need a piece of paper saying that we're allowed to do that. We've been doing that consistently, regardless of what the agency is legally saying we're allowed to do. So, for example, this vigil that we're organizing, it's just all of us just came together and started talking, and now we're organizing a vigil for Tuesday night to be in community together. It's off-duty time. So yeah, the union is about the people, and I would say that's how we're still active.
And maybe you could just, in closing, say a little bit about the FUN, the Federal Unionist Network, because I think this gets to this other point.
Yeah, so the Federal Unionist Network, I'm on the steering committee for that group, but basically what that group is a network of federal workers all across the federal sector, and across different unions. And we are just folks who are interested in strengthening our unions, making our unions fight for common good demands, and building unity to fight back in a sectoral way against many of the attacks that we're facing that are affecting all federal workers, and the public services that we provide. That's our main focus is that we all came into federal service because we care about the public and serving the public, and we can't do that when our staffing and funding is being cut. And so we think that our unions, we should be using them as tools to fight for and to protect and defend and expand public services for the American people.
Great, thank you. Are there any sorry, Are there any further questions for Mark before he leaves? Mark, do you see the chat? I'm not really.
It says, are you getting bullied by the administration? I would say, yeah, of course. We get threatened with retaliation or, other things. But I would just say that like unions have experienced a whole lot worse and workers have experienced a whole lot worse in our history. I mean, I don't know if we've experienced worse than yeah, there's been a lot worse, and we just have to keep fighting and doing it collectively, and that's what gives us courage and confidence is when we act together in a group, and that can help us overcome that fear and also the any bullying or attacks that might come.
Thank you so much. Thank you, Mark. And if you can hang around, that'd be great. But if you can't, we understand that you've got places to go and things to do. I'm going to jump in. I'm Suzanne Gordon, and I'm with Russell Lemley, a co-founder of Veterans Healthcare Policy Institute. I also am a senior policy analyst here, and I've been writing about healthcare in general for something like 30 something, 40, I don't know how many years, a long time. And written a lot of books, edited a book series for Cornell University Press on healthcare, and have written several books on VA. And I want to home in, I always get the two confused, on a couple of things about these cuts and caps, and also about a focus of privatization that I'm not sure we've paid enough attention to. So clearly, and there's been not only cuts and caps, but there's been, since the Trump administration came in, and it's continuing to this day, really the creation of a hostile workplace for VA employees and an erosion of what we call in patient safety psychological safety. And so staff cuts not only cut staff, and VA has, when they first came in, they immediately sent letters out, DOJ sent letters out asking people in the federal government and the VHA to resign because they weren't contributing to American prosperity and they could do more productive work. And I quote elsewhere, I'm shocked that more VSOs and veterans groups didn't protest that, because if I were a veteran and I were told that working with me wasn't very productive, I would be incensed. But that was their introduction. And now they've resorted to calling VA nurses domestic terrorists. So it's kind of a spectrum. But there were cuts in probationary employees were fired, and then research contracts were cut of researchers. And then there was the announcement of 83,000 job rifts that would be initiated by Secretary Collins. And then many groups, including ours and unions and so forth, protested that. And then they said, oh, that's all right. We're not going to cut 83,000 workers. We're going to just not fill positions vacant from attrition. And that may not sound bad to the public, but sorry, I seem to have a creak in my throat. But in VA, that's very significant. And in any organization, because every organization has people leave because they retire, they die, they go off for another job, whatever, they burn out. But a healthy organization immediately fills those positions. VA has always had trouble filling positions because of several things. One is that they have very cumbersome hiring procedures, which were made worse by the Trump administration's Human Resources Modernizing Plan, which didn't modernize, but really crippled hiring, even in different administrations. It sadly wasn't reversed by the Biden administration. And also because for certain for certain clinical disciplines and certain disciplines, the salaries are not competitive. For psychologists and mental health people, they may be. For some clinicians, they may be. But for example, nurses like Alex Pretty, when he signed on to work at the VA, he could have earned more money in the private sector. Social workers too, certainly medical specialists and so forth, and administrators. And so you say you're not going to fill positions, and that's a significant staffing cut. It's not a RIF, it's not a reduction in force, but it fundamentally is. And when your staff is telling you we need those people, that is part of the creation also of the kind of hostile workplace that we've seen being implemented in VA. I don't know if folks recall, but there was at one point, VA workers were told they should write every week like 5 things they do for people, in their job, like it wasn't self-evident. And then in December, Secretary Collins announced that he was capping positions. Russell is going to talk more about that, capping positions. And that saying that these were not needed, even though employees were telling managers and telling the secretary that they are needed. There's another impact that I want to point to before Russell talks, and that is an aspect of privatization that I don't think we as an organization or anybody has focused enough on. And that is, so there's the aspect of privatization where you outsource patients to the private sector and you defund the VA. But there's a kind of privatization where you import the worst private sector practices of American medicine into the VA, right? And you impose these on VA staff. VA clinicians who could make more money working elsewhere, and certainly make maybe even the same money dealing with less complex patients, because VA patients are very complex, right? They're older, sicker, poorer, have more mental health problems, can be more, as they say in VA, disruptive, which means violent, a small subset. They're challenging patients because they have so many comorbidities, so many presenting problems. I mean, the average senior citizen like me over 65 has 3 to 5 presenting problems. The average Vietnam vet has 9 to 12. Veterans come at you with if you printed out a chart that's like this, and doctors tend to run in the opposite direction. So VA staff are taking on very challenging patients. They have done so willingly because they wanted to work in a mission-driven system where they had a good work environment. And there are many VA staff, and I invite them to speak out. Some of them retired, so they don't have to worry about it in the question period. But I've been told by many of them that, we want to work with veterans. We want to work in a mission-driven system. We don't want productivity pressures imposed on us like they're imposed in the private sector. In the private sector, primary care docs have 10 to 15 minutes. In VA, they have half hour to an hour. They work in patient-aligned care teams where they have support, administrative support. They have teamwork. They have psychologists and pharmacists and social workers working with them, not just, that they refer to. And they have a psychological safety. They've had a union voice, and where they've been able to raise problems and challenge. A nurse could challenge a doctor, for example, if they felt they were giving the wrong drug. And that is all disappearing. They really are throwing everything out there, creating chaos and fear and a lack of psychological safety. There's a very vast literature for those of you. Psychological safety just means that you could raise issues, have conversations, express insights and concerns without fear of retaliation. I can't quote a VA doctor who works in VA by name telling me how wonderful the care he or she gives to patients in an article anymore because they could get fired for saying something good about their agency. I mean, that says a lot. And psychological safety, there's a vast literature that links that to patient safety. The issue of trade unions being trade union contracts being aggregated and trade unionists being chased out of the VA, or you can't mention the word union. A lot of people just look at that and they think, oh, well, that's kind of a shame, or they may be iffy about unions, or they may think it's a labor management issue. It's a patient safety issue when you tell people they know how they no longer have a voice. And the VA was unique in that it gave people a voice, and it created teams in which, a clerk could tell something to a primary care doctor or even a surgeon. Don't cancel that appointment, because I've been trying to reach that guy for 3 weeks and he'll never come in again. People's knowledge from the bottom to the top is respected. When the VA did its groundbreaking research on how to prevent the spread of the infection, methicillin-resistant Staphylococcus aureus, MRSA, they didn't just go to doctors and nurses, they went to housekeepers and asked them, what can we do? And they were successful at reducing MRSA infections because they did that. I have just heard from a credible source that they're about to eliminate the PAC teams, the patient-aligned care teams in VA. I have to confirm that, but it wouldn't surprise me because they're about to eliminate the VISNs structure, the Veterans Integrated Service Network structure, which people don't think is very sexy, but that was the architecture that was developed that allowed a system that was based on individual hospital fiefdoms to turn into, that were kind of in competition and never worked in collaboration and didn't know what somebody 50 miles away was doing, to turn into a system which has advanced, everything from barcoding to integration of mental health and primary care, and they're going to throw that away. They're pushing productivity pressures on VA providers. And so the privatization that's occurring that I think we have to stop is not merely the defunding that it's a huge problem, obviously, and outsourcing of patient care, but the effort to destroy morale, the care environment that produces such good outcomes inside the VA, and to destroy a lot of the, as I said, the scaffolding and the relationships, the human relationships, the bureaucratic scaffolding, the human relationships that allow people to deliver such good care over long periods of time to difficult patients. VA primary care, there have been studies that have shown that it's a much better place to work and a much better model than the primary care model that is causing so much burnout and is such a failure in the larger system. We could be about to lose a system, if we don't defend it, that does everything well that the broader American healthcare system does not do well. They're fragmenting care in an integrated system. They're eroding the ability of the system to deal with social determinants of health, homelessness, legal issues, vocational rehabilitation. And where are they going to replace it in the private sector? I mean, the private sector, as a report by VHPI that I did about private sector to capacity to handle veterans, the private sector, as those of us who are non-veterans and struggle to get our own health care, can't accommodate, 248 million adult American patients. And how is it going to accommodate an influx of 9 million veterans, particularly after the big, beautiful bill where hospitals are closing, hospitals are laying off staff or having hiring freezes, We have 123 million people living in mental health deserts, 89 million people living in primary care deserts. There is no care there for many of the veterans who will be sent into the private sector. And this is something that I think we really have to emphasize. I know Common Defense has done an amazing job at looking at how and tracking and mapping, and Alex Rich is on the phone, is on the Zoom call, and maybe could talk about this, the delays in care that this is creating. And Russell, I know, is going to talk more about this, but you know, the solution of Collins and his comrades is send them to the private sector. Where? I just got a weird message from my primary care doctor. This is the third one I've had in 10 years because they keep disappearing. And it terrifies me, like, oh my God, I hope I'm going to knock wood. I hope she's not retiring too or leaving, because where am I going to find another primary care doctor? And I'm, you know, a healthcare researcher, right? Imagine you are a homeless vet or a mentally ill vet, and I live in San Francisco and you're in the middle of nowhere. What are you going to do? So I think we need to think about all these things. And I guess the thing that I want to conclude my talk with, and I think we all have to think very hard about this, is we have to reach veterans who feel that they have a bit of buyer's remorse, because we have an election coming up. And we have to be very clear if, and I hope that it's not an if, but a when Democrats retake at least the House, not the Senate, we know what we want to ask them to do to start reversing these problems on day one, because we have an opportunity to reverse the problems that we're talking about today. From my conversations with VA employees, they need hope. They need VSOs speaking up for them and telling them that they appreciate them. They need hope from Democrats who say they'll fight for them. They need hope from their patients. We need to stop the tsunami of I'm out of here's and hold on to people for another year so we can stop the bleeding and rebuild. And that's my message. And I know Russell, my colleague, has a lot more to say to you, and will give you a lot more sense of the direction that we need to be going in. Russell.
Okay, thanks, Suzanne. I'm going to mostly focus on mental health, but not entirely. And actually, I just want to start by acknowledging last Thursday's Senate Veterans Affairs Committee report, Breaking the Pact. And Jasper, I'm not monitoring. There we go. Thanks. Jasper's just putting the link in. If you missed it, it was a phenomenal 52-page report that covered many issues that we're touching on here briefly, particularly in terms of the staffing cuts. I also just want to draw your attention that the report, because it was being drafted over the summer and fall and early winter, did not account for the ceiling caps. And I want to talk a little bit more about it. I know that Suzanne just mentioned the caps, so did Mark. But you can read that Senate report, which is pretty devastating, and it doesn't even include the worst thing that has happened in the last 6 weeks. And we'll talk more about those. Now, the caps are not official yet because all the visits have reported back to central office, but central office has not put out the final stamp of approval on exactly what those are. But they're going to amount to an additional 25 to 30,000 positions that are being eliminated from organizational charts, on top of the 30,000 that had already been eliminated during the DOGE cuts earlier in 2025. So that overall, across mental health and really across the whole VA healthcare system, we're looking at about 15% cut. And when Mark was talking earlier about doing more with less, this is exactly what he's talking about. It's very difficult to be operating with a 15% cut without a 15% cut in demand, which there has not been. And particularly in mental health, demand actually just has gone up for the last decade, and continuing to go up. And I'll talk a little bit more about that in a second. And as Mark also alluded to, the VA has characterized these cuts as just eliminating positions that have been open for 6 to 12 or longer amount of time, some of them held over from COVID. But that's really a euphemism because most of those positions were frozen. So it isn't that they weren't needed, is that there was an inability to hire when they were vacated over the last year or two. Um, and it's a silly argument to say that a position that is empty isn't needed because you have no choice. Now, it is true, as the VA has been announcing, that some of the vacancies are being recruited. So it isn't that every position that is vacated and every position that's empty is not being recruited. It's just the majority of them are being eliminated. Some of them are being left and then being recruited for. But just keep in mind, it's really just a euphemism that the VA is using, that they're not needed because they're unfilled. Now, what's been instituted going forward is the cap, which means this is the maximum number of positions that a healthcare system can operate. If demand goes up at the medical center or in its clinics, which in mental health, as I said earlier, is predicted, the excess has to be sent to the community. There is no additional capacity at the local facility. And when there's excess sent to the community, the associated reimbursement goes to the community. So what you can expect actually in a year is that the caps will get lower. I mean, they're already devastating. And what we can anticipate is they'll have even lower caps because when you have excess overflow going to the community, the reimbursement follows it. And the facilities will have less money and less positions in a year. Now, the report that the Senate issued last Thursday talked about an average wait time over the last 12 months for mental health had gone from 17 days average to 35 days average. Now, that's devastating in terms of how long that you have to wait now for an appointment. But it's worse when you remember that the access standard for mental health is 20 days. And any veteran who has to wait more than 20 days is automatically given eligibility for community care, which means now if we're at 35-day average, the majority of new mental health episodes are eligible for community care. And all the problems that we were just talking about kind of follow that. This is independent of how long the waits are in the community. I don't think there is a kind of an official designation around how long the wait is. My informal one, in terms of many of the mental health colleagues that I continue to know, is that we're talking about 2 to 3 months. And I should say, continue to know, I worked in the VA for 38 years. I was a chief psychologist at the San Francisco VA for most of that, retired 6 years ago. Now, inside the VA, mental health has an official staffing ratio of 7.72 FTE of mental health staff per 1,000 patients. This is not excessive, but it's kind of an adequate number that you could then adequately care for your patients if you had that number of mental health staff. Now, that has been thrown out the window so that many stations now are operating with far less mental health staff per 1,000 patients, which of course is going to do a couple things, not only send more veterans to the community because of the wait time, but it's going to do many other things. It's going to actually, with fewer staff, you're going to lower the number of average mental health sessions per veteran. The opposite of which is now true in the community because the VA issued a directive that said that veterans sent to the community for mental health care gets an automatic year's worth of treatment, and then you can come back and be renewed for more. So you're getting more sessions per veteran in the community while the number inside the VA is both formally and informally being reduced. In terms of some of the asks, like that Suzanne was mentioning at the end of when she was speaking, one of the things we have to have is kind of a staffing ratio, not only in mental health, but really for all care, with some teeth in it. Otherwise, the capacity will not match demand, and there'll be even more private sector referrals and all the problems that follow from that. One of the things actually I'm also hearing is that in some VA facilities, residential programs are having bed closures so that they're not operating fully because they don't have enough staff. There are even psych units that are being closed with too few staff. It's worth mentioning that, a year ago, there was a return to office directive, and that led to many mental health employees quitting because they were doing telemental health from home, And now they're being forced to, for long commutes, to come into a federal facility and do telemental health from the facility, which seemed inane. And it was a great loss. That has not been reversed. One of the things I would mention that if you have not looked at the Honor Act, which was introduced by Senator Blumenthal a couple months ago, there is inside that legislation a return to office rescission. It's also true that telemental health has never counted from the very beginning of kind of following Mission Act, never counted in terms of counting as access to care. Even when the VA can provide it much faster in the community, the Honor Act actually would correct that. Wait times are still not known to veterans when they're sent to the community. Sometimes VA providers are aware of it. My understanding from VA employees is that they are being asked to not tell veterans what the wait times are because it's characterized as arm twisting. So I was talking with one colleague not too long ago who said the wait time locally there is 70 days for a mental health appointment. And the instruction is do not inform veterans because you're going to be seen as anti-community care. Now, what's missing is veterans don't know what the wait times are in the community. The Honor Act actually would fix that too. So everything I've just run through is about mental health. If you just think kind of zoom out across all VHA with the cuts, just the cuts in December, I'm not talking the ones that preceded it in 2025, it's about 1,500 positions that were eliminated per VISN. And that's how we get to kind of the additional 25 to 30,000 across the board on top of the other 30,000. I just want to say one thing about Suzanne's comment about privatization, which Suzanne, you covered beautifully, which is that my understanding is that the VA is now looking to take the position that every place that they have had the gold standard, the platinum standard, whatever you want to call it, in terms of quality of care, they're being told to think about reducing the VA standard to match the private sector if the VA has better standards. So, for example, the Directive 1150.01 potentially could be gutted because it actually has higher standards than the private. One of the examples of that I'll give, and then I'll close, is that the VA for its residential programs has, for a long period of time, used CARF, the Community on Accreditation for Rehabilitation Facilities, and the Joint Commission, dual accreditation, of which CARF is actually kind of the more strenuous and important one. But the private sector does not and has not used kind of the dual accreditation standard. So one of the things that happened 6 months ago is that the VA actually eliminated its contract with CARF, thereby lowering its standard for residential treatment to the lower standard the community has. So I'll just close. I mean, it's just kind of another example, Suzanne, of what you were just saying in this kind of reverse privatization. So with that, I will go out.
Yeah, it's interesting. I'm writing a book about Ken Kaiser and how he transformed the VA, and it's quite interesting that that he was able to create a socialized medicine system in the United States the year after the Clinton plan completely went down in flames, in part because it was under the radar and nobody paid attention to it, and Clinton was otherwise occupied, like with purple dresses or blue dresses or whatever. When Bush came in and they started getting a lot of press on the VA and how, they started having articles in Harvard Business Review and Business Week and Forbes about what the VA could teach the private sector, they started cracking down on PR on the VA. And this is just a sort of continuation of that. I think this is, very dangerous for not just veterans, but all American healthcare and every American, because we need a better standard than is in the private sector. I also want to mention that, there's been very little attention to what staffing cuts do to the VA's ability to teach the next cohorts of American healthcare professionals, because what I've been told is that they're you have to have staff time in order to teach, right? To supervise trainees. And accreditation of VA professional training programs depend on not just on both enough patients and staff time. That's going to be jeopardized. And then all of us will suffer because the VA is so pivotal in the American healthcare landscape. And finally, as Russell and I pointed out, I think we've been writing so much on this, I can't really remember which article, but they're about to launch this deeply failed electronic medical record into 13 different places around the country. And all the reports suggest that this deeply flawed and frightening electronic medical record has been, that it's staff vigilance that has protected veteran patients from adverse drug reactions and even death. Staff vigilance on, and if you have less staff and the staff are overloaded with, just patients because there are not enough of them, they're not going to have the vigilance to protect patients from this disastrous, again, privatization of the VA once excellent health record. So I'd like to open up for questions or comments. I'm not very good at this, but Gerald Stein, I'll just answer this one that's up here. Gerald Stein said, please provide documents, a 17% cut in VA healthcare budget. That if you look at the VA budget, 2026 FY budget in brief, you will find that stat. Alex, could you comment or?
Yeah. Hey, everybody. Alex Rich. I'm the data director for Common Defense. I have a little bit of an update on our vhadata.org site if there's time for that. It's kind of centric on the mental health picture, and I think it kind of does a decent job of distilling a lot of what we've talked about into a little bit tighter package that's maybe a little bit more digestible for non-expert audiences and some of the people we're trying to convince. So let me know if and when we've got time for that. Would be happy to run through that demo.
So Alex, would you put your maybe your email in the chat? Actually, we would be happy to work with you on a VHPI forum on that. I mean, if we could talk about that offline, I'm sure maybe people could raise their hands. If Alex, could you just maybe explain what you're talking about, and then folks would have a better sense of what they might be signing up for.
Yeah, so big picture, this is still in beta, and I'm having to control access to the broader set of the data to a limited set of policymakers and advocates, simply because we're kind of under-resourced at the moment, and this is just me coding nights and weekends and holidays. But we found some staffers on the Hill who were having a very hard time tracking wait time data. They were going into the Access to Care site and downloading one day of one facility at a time. I wrote code to scrape them all every morning and to go through and visualize them and to rack and stack them. And I built a visual analytic environment where you can go through and look at your state, your district, and specific facilities and see what's going on. I've also written a summary of the mental health care picture. Big picture, 66% of all facilities in the country are missing that 20-day target for individual mental health wait times for new patients. Among that, 123 have wait times that are out past 60 days. So I think this is a critical situation that we've never really been able to distill in terms of a clean data-based presentation, and I'm really excited about where we can go with it.
Yeah, and we're really excited to work with you about how we could even marry your data with a visualization of private sector incapacity to handle these veterans, because if they have delays in the VA, good luck getting that resolved. I mean, in the private sector, and as Russell said, that's something that the government doesn't want, this particular government doesn't want you to know about. So thank you, Alex. If people could maybe put in the chat if they'd be interested in a demo, and we could certainly organize that. I think that would be super. to help people see that. Are there other questions or comments, or let me see, I'm not sure I'm equipped to see if people's hands have been raised, but
Someone's asking if we know what the budget in the big bill coming Friday is. The VA budget and a big bill on Friday. I'm not sure exactly what that bill was. So maybe that's not relevant. If anyone else has questions, they can put them in the chat, or they can.
I wonder if like some folks would maybe like to talk who just left VA about what they feel. I don't know, Glenn, is it inappropriate for me to ask you, Glenn Graham, to maybe just tell folks about what would be happening, you know, the kind of care that folks wouldn't be getting if they were dependent on the private sector. Glenn was a neurologist, and Glenn, you can say who you are.
Sure. Well, I was the National Director of Neurology Clinical Programs when I opted to leave the VA late last year. But can people hear me okay, by the way? I'm not sure my video is working, but whatever. We have, for example, within neurology, we've heard a lot about mental health. We have a lot of special programs, and my direct responsibility was for 4 centers of excellence and for neurologic conditions that are common among veterans, and also 3 teleprograms. One, essentially almost like a center of excellence, provided acute care that veterans could get at a VA, often that wouldn't be available in a small community hospital, using intravenous lytic therapy for stroke, also for general neurology and for epilepsy and EEG. Several of the key administrators, I think largely driven out of cruel fear from threats that they might be left with nothing, kind of jumped the gun a little bit and took early resignation or early retirement because they couldn't afford to be left with nothing, you know, no job, no health care, and no source of income. I can't go into details, but I've learned that several other high-level folks are considering other jobs. These are people who have leadership roles in these various centers and large national programs, citing burnout, citing the lack of support, since some of their key support are among those that that I mentioned that have left the organization. We have a lot of acting people who are temporarily running neurology. One of whom I suspect, one who stepped down out of fear for her position, another who is likely to retire very soon, and there is no hint of those positions being advertised for or being replaced. So I think there's great need to be concerned. You know, for example, some of our centers of excellence provide interdisciplinary, multidisciplinary care that you can't get in the private sector. We don't have a center there, but our ALS care, you know, veterans get adaptive equipment that they would not get from Medicare or any private insurance. And we've seen people with various sorts of chronic conditions get relief, let's say for pain tied in with a lot of mental health issues and chronic headaches, with a truly interdisciplinary, multidisciplinary approach combining counseling, group treatment, pharmacotherapy, devices, other sorts of alternative and complementary medicines to get their life back. And I've talked to many veterans who have, you know, specifically said that they knocked around both inside and out, certainly outside the VA for years before they found a center of excellence that could put the pieces together to maybe not make their life perfect, 0 out of 10 pain, but get it from an 8 or 9 out of 10 to a 4 or 5 out of 10 and get them their life back. And this does not exist in the private sector, because I know I talk to people all the time who look for things like this in the private sector and they don't have access to it. So that's a little bit of my 2 cents.
Thank you so much, Glenn. Is there anybody else who we have like 3 more minutes, might want to comment on this? This is my grandson, everybody. Sorry. He's going to be another VA supporter, right? Okay,
I will say, Suzanne, I will say very quickly that to try to provide support for people who care for neurological conditions, and that's not just physicians, but therapists, nurses, neuropsychologists, health psychologists, etc. We have a group that is a federally chartered but non-federal entity, nonprofit, called the Association of VA Neurology Services, also known as AVANS. That will be meeting in March to try to bring things together, and former Secretary David Shulkin will be our keynote. So I'm
great.
very interested to see what Dr. Shulkin has to say about the current state of affairs.
Yes, thank you so much, Glenn. Thank you. We basically have 3 more minutes. So I'd like to give Russell a couple minutes and then I'll conclude. So Russell, what would your closing take-home message be?
On the theme of what you were saying earlier, Suzanne, around where we need to kind of focus going forward. One is to preserve as many of the aspects in the Honor Act as we can going forward. I only summarized 3 of them. It is a fantastic piece of legislation, something that we should be focused on and trying to help get over the line. Especially the issue around staffing and staffing ratios that's embedded in that. We're going to lose the fight unless there are enough staff to meet demand. That's kind of embedded in that particular piece of legislation. It's a key piece. And whether it comes in that form or any other one, inadequate amount of staff is just, separate from the issues around morale and burnout and retirement that are obvious that we started with. It's just going to force excessive demand to go to the community and all of the redirection of funds that go with that.
Right. And I think I think we have to really hammer home to veterans that, except in some places, there's just not going to be enough care. And also, I think we need to help like municipalities and states understand what the loss of the VA would mean to the quality of healthcare. And also we at VHPI are working on something that hasn't been really emphasized, which is the economic impact of VA closures. I mean, in San Francisco, you lose the VA, that's 3,800 jobs. In many areas, the VA is the largest employer. That nurse who loses her job and who is not going to be able to get a job so easily in this new environment of the big, beautiful bill, because hospitals aren't hiring, they're laying off, is going to lose her health care. She's going to lose her ability to get a roof repaired. There's all kinds of ripple effects, not to mention that if they ultimately, which I think they will be forced to do, cut back on disability payments, you're going to lose the billions of dollars that are running around, circulating around states because of comp and pen. So I want to really thank you all for coming. I think it would be really useful for all our different groups and all our different folks to start compiling their to-do list for the Democrats if they get in office, because there's going to be a lot of people going to anybody who, if they win this next election, because there's going to be a very long to-do list, and we need to get there and tell them what very concretely needs to be done to not just save the VA, but to improve and expand it. So thank you so much for coming. Jasper, this will be available for folks who didn't get a chance to see it. Is that correct?
Yep, it'll be on our YouTube, and I'll send that out in our next newsletter.
So thank you so much. And we would love to encourage all of you to please sign up for the VHPI newsletter if you already haven't. And we can always use donations. So please consider donating 25,000, whatever you've got lying around. So thank you. And we hope you enjoyed it. And we just, really want to just take a breath and give our thanks for people like Alex Preddy, the caregivers who every day sacrifice, not just for veterans, but for making healthcare better in the United States. Thank you so much.